Welcome to all of you, and thank you for inviting me to talk about pulmonary infections complicating ARDS. This is an important topic, but also an extremely complicated one. And first of all, because there are not many original papers on the topic. And then because it combines two huge issues in ICU, pulmonary infections with currently no gold standard for diagnosing, and ARDS, a syndrome which regroups a wide range of disease. I have no conflict of interest in this presentation. Pneumonia and ARDS are closely interconnected. Pneumonia is the most frequent cause of ARDS. Whatever the initial lung injury, patients with ARDS are prone to develop secondary pulmonary infection, namely ventilator-associated pneumonia, VAP. And VAP could worsen ARDS. VAP complicating ARDS appears to be a common problem, affecting between 20 and 40% of the patients. But study on prevalence and incidence may be flawed because of the absence of a gold standard for VAP diagnostic. I will not discuss this point. After this brief introduction, my talk will be focused on the following topics: pathophysiology, diagnostic challenges, issues with antimicrobial treatment, prevention of infection. I will not talk about ARDS, COVID-19 and infection because this topic is covered elsewhere. The high frequency of pulmonary infection in ARDS patients may be explained by traditional factors such as bronchial contamination due to endotracheal intubation, but also because of impaired local and systemic defenses. On the left of the slide, you can see that microaspiration of oropharyngeal secretions contaminated by endogenous flora is the major route for microbial invasion. The amount of bacteria around the tracheal cuff is estimated at 10 to the power of 10. Uncommonly, VAP may occur in other ways. The stomach has been suggested as providing potential reservoir for certain bacteria colonizing the oropharynx. Some researchers have postulated that bacteria could colonize the inner face of the endotracheal tube and that embolization into the lungs could occur during suctioning of bronchoscopy. On the contrary, direct inoculation or via an hematogenous spread are uncommon. On the right of the slide, you can see that the impact of bacterial invasions depends on both bacteria virulence and inoculum. In ICU, the balance between bacterial invasion and immune defenses are quickly altered, and colonization of the proximal airways occurs quickly in intubated patients. I would like to talk about two new insights that could explain that patients with ARDS are at risk of pneumonia, dysbiosis and hyperoxemia. First, dysbiosis. As you know, the lungs have been considered a sterile organ for decades because microbiological culture techniques had shown negative results. However, culture-independent techniques have shown that healthy lungs hide a diverse and dynamic ecosystem of bacteria. Dysbiosis is often defined as a microbial imbalance, and this imbalance appears quickly in ICU patients, as you will see in the very nice review from Jean-Damien Ricard's team. Again, on this line is drawn the conventional concept of pneumonia in ICU patient I talked about a few minutes ago. But it has been postulated that hospital-acquired pneumonia is not an acute condition slowly induced by the contamination of the respiratory tract by endogenous pathogens, but the result of dysbiosis between the lung microbiome and mucosal immunity. And this concept could lead to changes in prevention methods and treatments, as described in this nice paper from Roquilly and colleagues, and especially in ARDS patients at high risk of pneumonia. Why not, for instance, respiratory microbiota transplant? Secondly, hyperoxemia is a very important issue. In this retrospective observational study performed in a single ICU, hyperoxemia is independently associated with PAP. Hyperoxemia can promote VAP because it favors acute lung injury by itself, called hyperoxic acute lung injury, but also denitrogenation, a reduction in surfactant production, and bacterial clearance. What about diagnosis? The diagnosis of superimposed pneumonia in patients receiving mechanical ventilation because of ARDS remains a difficult challenge. Indeed, the clinical criteria commonly used to diagnose VAP, fever, leukocytosis, purulent sputum, and new or persistent radiographic infiltrate are almost always present, at least at some time in the clinical course of patients with ARDS. And ultimately, the diagnostic should require a histopathological examination, which is not realistic in such severe patients. Therefore, the diagnosis is a combination of clinical, biological, radiological, and microbiological criteria. The role of modern tools, molecular methods, metagenomic sequencing remains to be evaluated in this setting. What about antimicrobial treatment? Epithelial lung fluid, ELF, is considered as the site, the compartment of antimicrobial activity against lung infections caused by extracellular pathogens. There have been an extensive number of studies conducted during the past 20 years to determine drug penetration into ELF and to compare plasma and ELF concentration of anti-infective agents. The majority of these studies estimate ELF drug concentration by the method of urea dilution and involve either healthy adults or patients undergoing diagnostic bronchoscopy, which is far from ARDS patients. Large molecules such as vancomycin, teicoplanin, and colistin will have poor lung tissue concentration when given intravenously. ELF plasma concentration ratio is far below 1. Beta-lactams penetrate into lung parenchyma better than other hydrophilic antibiotics, but ELF plasma concentration ratio remains below 1. Among hydrophilic antibiotics, ELF plasma concentration ratio for tigecycline is around 1. Lipophilic antibiotics, but also antifungals and antivirals, will have good lung tissue concentration, ELF plasma concentration ratio above 1 after intravenous administration. What about prevention? There is no single preventive measure that will completely avert this complication, and such patients at high risk of that must be approached with a package, a bundle of preventive measures. Expensive device could have a place in this particular context, such as automated endotracheal tube blood pressure monitoring. And selective oral and digestive decontamination should be considered. The effect of SDD on mortality was greater in patients with high overall mortality, such as ARDS patients. However, study testing SDD were conducting in ICUs where the prevalence of multi-resistant bacteria was low. A growing body of evidence says that indiscriminate oral care with chlorhexidine may be harmful. Michael Klampas and I listed all the data available in RCT, meta-analysis, and observational studies, and oral care with chlorhexidine should not be used to prevent pneumonia until further data become available. To conclude, I invite you to read this recent review by Charles-Édouard Luit to complete your knowledge on the subjects. Potential for improvements are numerous in all fields to identify early the imbalance between the host and the microbiota, to develop accurate early methods of pathogen identification, to evaluate the impact of new molecular methods in diagnosing pneumonia, and to evaluate the benefit of the use of SDD in ARDS patients in ICU with a high level of bacterial resistance. Thank you for your attention.